Welcome Dr. Suajit Poddar, who will guide us through the techniques of one-lung ventilation. Dr. Suajit Poddar is currently serving as an assistant professor in the Department of Anaesthesiology at Kastuba Medical College, Manipal. His professional interests lie in ultrasound-guided regional anesthesia. He is also actively involved in the specialized areas of the onco-anesthesia and pediatric anesthesia, contributing to improved patient care and advanced anesthetic techniques in these critical fields. Sir will be guiding us through the skillful art in thoracic anesthesia. Over to you, sir.
Hello. Yeah. Am I audible? Yes. Thank you, ma'am, for the introduction. So it's a pleasure to talk about a topic that is exciting as well as mildly terrifying, the one lung ventilation. So when I saw the title, I immediately thought of the Lord of the Rings, like one ring to rule them all. But I can see a lot of blank faces here, so I think that movie is little outdated. So we can relate it to some better. So we have now here Mr. Thanos, who wanted to acquire 6 infinity stones. So he wanted to take care of the time, space, and reality. And with a snap, he wanted to remove 50% of the population. Sometimes when I do my surgical onco cases, I also feel like Thanos. Don't go by the looks, okay? So I can also control the pressure, the ventilation, the oxygenation, the saturation, the surgeon's grumpy mood, and also my time for coffee, all at once. And the best part, I can also snap, and 50% of the lung will not get ventilated. Interesting, isn't it? So let's take a clinical scenario. A 62-year-old man with a right lung carcinoma posted for right upper lobectomy. You have placed the double lumen tube and checked the position. And the surgeon says, "Doctor, please collapse the lung." So as soon as you collapse the lung, your saturation drops to 89%. So the surgeons give you a death stare and ask you, "What's happening, doctor?" And you hurriedly go to your endotracheal tube between the drapes and you wonder, what is this happening? Is this hypoxia? Is this atelectasis? Or it is just a bad karma that I was not attentive in this lecture? Just saying. So let me try to explain this complex topic as easy as possible. So the next time, if a scenario like this happens, so you know what you should do and you might even enjoy it. So what is one lung ventilation? What do you mean by that? As the name suggests, it is an anesthetic and a ventilatory technique where only one lung will be ventilated and the other lung is intentionally collapsed and not ventilated. So why is it necessary? So we can divide the indications for one lung ventilation into your absolute indication and relative indication. Let's go for the absolute indication. The first point is, if you want to isolate your lung from the other to avoid any spillage or contamination, in cases like lung abscess, in cases like your massive hemorrhage, then to control the distribution of ventilation, in cases like bronchopleural fistulas, any tracheobronchial tree disruption, surgery on your major conducting airways, and if there is a presence of any cyst or bulla. And the third option should be if you want to do any bronchopulmonary lavage unilaterally. Now you know the absolute indication. Let's see the relative indication. It can be divided into a high priority, like your pneumonectomies, your upper lobectomies, and your thoracic aortic aneurysm repair. The low priorities can be of your lower lobectomies, your esophageal resection, and your thoracoscopic procedures or your thoracoscopic spine surgeries. So now you know where you should do your one lung ventilation. Now let's see where you should not do you can't do your one lung ventilation. So the contraindications are the presence of any intraluminal mass in the trachea or carina. If there is any hemodynamic instability in the patient, avoid your one lung ventilation. If the patient is not able to tolerate your one lung ventilation because of severe cardiorespiratory distress, like your severe COPD or your severe pulmonary hypertension or your severe hypoxia, try to avoid your one lung ventilation. Now that you know the indication and contraindication, let's see how the lungs changes when you ventilate in both the lungs and when you ventilate only one lung. So you can see here is a schematic diagram of the lung within the chest wall. So this box-shaped structure, I think you can see, yeah. So this box-shaped structure is your chest wall, and the lung, which is globular in shape in purple color, is your lung. So the lung always tends to take a globular shape because of two things. First is your gravity and your lungs' viscoelastic nature. Okay, now you all know that lungs always tries to collapse inside, and the chest wall always tries to collapse out, recoil outwards. So there is some negative pressure in your intrapleural space. Now, one more factor which gets added up is the gravity. The gravity tries to pull the lung down. So because of all these three things, you can see the space here is larger compared to the space here. So today, the second lecture by Dr. Pankaj Kundra sir, where he has mentioned, according to the Boyle's law, at constant temperature, if the volume increases, what will happen to the pressure? The pressure will decrease. The same thing happens here. See, here the volume has increased, so what will happen to the pressure? The pressure will decrease. Now your intrapleural pressure at the apex is your minus 10 centimeter of water, and at the base, because the volume has decreased, the pressure will increase and it becomes less negative to around minus 2.5 centimeter of water. Now we have your transalveolar pressure. So how much the lung can expand, it depends on your transalveolar pressure, which is the pressure difference between your lung cavity and your pleural cavity. So the transalveolar pressure, I think, is already mentioned by Madhuri ma'am. So it is the difference between your intraalveolar pressure and intrapleural pressure. So if you just replace the values, you will get the transalveolar pressure as plus 10 centimeter of water at apex and plus 2.5 centimeter of water at the base. So because of this transalveolar pressure or very high negative pressure, the alveoli at the apex will be grossly expanded. So this is how the alveoli at the apex will be and how the alveoli at the base should be. Now, at this point, when the person inspire, the alveoli which is at the apex cannot expand more. But the alveoli which is at the base will try to expand and it will be in a better position. So the right panel, what it shows here is your pressure volume curve of the lung. So where your x-axis is your change of pressure and your y-axis will be change in volume. So you can see here this alveoli, which is collapsed, not much expanded, it stays on the steeper part of your compliance curve. And the upper alveoli, which is at the apex, stays here. Now you see the pressure change. The pressure change is same in both the scenarios, both the alveoli, but the volume change is very high at the base compared to the apex. So we can conclude that the basal alveoli is better compliant than the alveoli at the apex. So in erect posture, spontaneously breathing patient, your ventilation will improve from the top of the lung or the apex of the lung to the base of the lung, as you can see in this graph. What will happen to the perfusion? Perfusion also will increase from your top of the lung to your base of the lung. Why it happens? Because of the gravity as well as the hydrostatic pressure of the vessels. So you will get a graph like this. Now, if you take a ratio of your ventilation here and your perfusion, just take a ratio, you will get you can plot a graph on every part of the lung. So you will get a graph like this. So your ventilation divided by your perfusion, the ratio. So let's concentrate on the third rib here. So at this point, you can see the ventilation and perfusion intersects. So at this region, the ventilation and perfusion will be equal. Okay, so if you take a ratio at this point, the ratio will be 1. So this is the region where you have your optimal ventilation and perfusion. Now if you see at the top of the lung, so here your ventilation is very high because your alveoli are all distended. Ventilation will be high than your perfusion. So in the ratio, you will get a value of 3. In this region, because the ventilation cannot match with the perfusion, it will add up to your wasted ventilation or alveolar dead space. At the bottom of the lung, you can see the rate of change of perfusion is higher compared to your ventilation. Both increases from the apex to the base, but the change of blood flow is quite more than your ventilation. So if you take a ratio at this point, you will get a ratio less than 1. So what does it mean? All the blood which is flowing in the alveoli at this point will not get oxygenated, and it will add up to your shunt. So we will see now why the apex has a dead space, this part has a dead space, and this part, the bottom part, has more shunt. So Sir John B. West, a renowned respiratory physiologist, has divided the lung into 3 zones, known as the West zones of the lung. In this image, you can see the 3 entities: your pulmonary artery pressure, which is in P small a, pulmonary alveolar pressure, P capital A, and pulmonary venous vein pressure as P small v. So there is an interplay between all these pressures. All these pressures will interplay and will decide the perfusion of the lung in 3 zones. So he has divided into 3 zones. So at this part will be your zone 1 at the apex, in the middle part will be your zone 2, and at the base will be your zone 3. So at zone 1, what happens? The pulmonary artery takes the blood from your right ventricle and it goes against the gravity. So as it goes against the gravity, your pulmonary artery pressure decreases. The alveoli is already expanded, so it will compress your pulmonary artery and your capillaries. So at this point, there will be no blood flowing in this region. So that is the reason why we will have only alveolar dead space or wasted ventilation. In this region, in your zone 2, now the pulmonary artery will go with the gravity and it will increase its pressure. So now the pulmonary artery pressure is more than your alveolar pressure. So here the perfusion depends on the difference between your alveolar pressure minus your arterial pressure minus your alveolar pressure. So this region will have your optimal ventilation and perfusion. But in any conditions where your pulmonary artery pressure decreases, like hypovolemia, or if you apply a PIP to the patient, this alveolar pressure will increase. So this zone at that point of time will convert into zone 1. And again you will get your wasted ventilation or dead space. Now coming to zone 3, at this zone is the base of the lung. So this zone receives more blood flow due to gravitational effect and higher hydrostatic pressure. So the blood flow here depends between the perfusion between your pulmonary artery and your venous pressure. So there is more blood flow occurring at this zone, and all the blood will not get oxygenated. So from here, some part will go for your shunt. So now we have seen in upright position, spontaneously breathing, how will be your ventilation and what will be your perfusion. Now we will discuss 3 scenarios. First scenario will be the patient will be in lateral decubitus position and the patient will be breathing spontaneously. The second position will be lateral decubitus position when the patient is anesthetized and muscle paralyzed. And the third condition where the chest will be open. And we will discuss these 3 scenarios in terms of our ventilation as well as perfusion. So let's see, in these diagrams, so somewhere here will be your zone 1, in the middle will be your zone 2, and third will be your zone 3. The same zone, let's transfer the same zones in this part of the panel. So now, somewhere on the non-dependent lung, the topmost part will be your zone 1. The dependent lung will be dominant in your zone 3, and 2/3 of your non-dependent lung and little bit part of your dependent lung will be your zone 2. So you can see here, the non-dependent lung, here the alveoli will be maximally dilated and they stay in this part of the curve, the bad compliant part of the curve. Whereas the alveoli on the dependent lung can be distended better, and you can see them on the steeper part of the curve. So here, with the same change of pressure, the pressure change is same, but the dependent lung can ventilate better than your non-dependent lung. So what will happen to the perfusion? Perfusion always follows the law of gravity. So where the gravity goes, the perfusion will be better. So the dependent lung will have better perfusion compared to your non-dependent lung. Now let's add one more factor to the same patient who was just lateral and breathing spontaneously. Let's anesthetize and paralyze the patient. One more thing which I have to mention is the dependent lung also has better ventilation because of one more factor, that is your diaphragm. The diaphragm will be pushed more because of the abdominal contents will push the diaphragm more. So the diaphragm will stretch out more. So if muscle physiology, if any muscle gets stretched more, will also contract more. That's why the diaphragm will move out more and give more space for the dependent lung to expand, giving it better chance for ventilation. So now, as soon as you anesthetize the patient is paralyzed. It removes all the factors which is going good for your dependent lung. First, it removes your diaphragmatic tone. Then, there is a static displacement of the abdominal contents. So the abdominal contents will push. The abdominal contents will push the dependent lung, and there will be some collapse at this region. Your intercostal muscle and other tissues which was controlling or which was holding the mediastinal masses will lose its power, and your mediastinal mass will fall on the dependent lung, again creating some collapse. So now you can see the dependent lung, which was first in a steeper part and the better compliant part of the curve, now it has fallen down, and it is in the bad part of your pressure volume curve. Now the non-dependent lung will come to your steeper part because there is no abdomen content at this region to put pressure, and at this point, if you ventilate the patient, so non-dependent lung will expand more and it will cause more ventilation. So we can tell in anesthetized patient, and when the patient is paralyzed, the dependent lung will get poor ventilated, non-dependent lung will get better ventilated. What will happen to the perfusion? It again follows the law of gravity. Dependent lung will get better perfused, and non-dependent lung will get less perfused. So that's what I told. Non-dependent lung is well ventilated but poorly perfused, and dependent lung is well perfused but poorly ventilated. Now you can see in both your non-dependent and dependent lung, there is a ventilation perfusion mismatch. So this scenario will hamper the oxygenation. So now let's one more factor. Now you have put the patient in the lateral position, anesthetized it, paralyzed it. Now the surgeon wants to open the chest. As soon as he opens the chest, there is our non-dependent lung is no longer confined to the chest wall. So at this point, if you provide two lung ventilation, the non-dependent lung can expand further, and it is a very good lung for ventilation. You can see it is in the steeper part of the compliance graph. Dependent lung, like I have explained in the previous scenario, it will stay in the poor part of the compliance graph. So the dependent lung is again poorly ventilated, non-dependent lung will be ventilated well. What will the perfusion? Perfusion remains same. It will be more in the dependent lung and less in your non-dependent lung. So let's summarize what we have seen here. So in a lateral decubitus patient, your perfusion remains same. The dependent lung will get better perfused. Only your ventilation will change. So when the patient is awake, spontaneously breathing, your non-dependent lung will get better ventilated. And when you anesthetize the patient and you open the chest, so at that time, your non-dependent lung will get better ventilated. So in the previous thing, at this point, if you divert all your ventilation to the dependent lung, which was already getting better perfused, what will happen? It will help to decrease your ventilation perfusion mismatch, and it might improve your oxygenation. Similarly, if you apply little bit of PIP of around 5 centimeter of water to 10 centimeter of water, the alveoli which was collapsed because of abdomen compression, suboptimal position, or because of mediastinal structure compressing the lungs, all the alveoli will open up and it will help for better ventilation. Now let's see what happens to the cardiac output. The right ventricle contracts and 100% of the cardiac output goes to your both lungs. Now you have make the patient in your lateral decubitus position. So you can see 60% of the cardiac output goes to your dependent lung because of gravity, and 40% of your cardiac output goes to your non-dependent lung. And you can see the shunt fraction, which is denoted by QS by QT, is 10%. 5% from both the lungs. It gets contributed 5% from both the lungs, and it makes up to 10%. Now at this point, you stop ventilating this non-dependent lung. What will happen? The 40% of the cardiac output will not get any oxygen, correct? So this 40% should come here and should make our shunt fraction to 50%. That's basic maths. But we are anesthesiologists, we have to put some physiology in this. So we see after you go for one lung ventilation, the perfusion or the cardiac output to your non-dependent lung has become half. Instead of 40%, it is almost 20 to 22%, and the shunt fraction, which was supposed to be 50%, has decreased to 25 to 27%. Why this thing has happened? It is because of an important physiologic phenomena known as hypoxic pulmonary vasoconstriction. So hypoxic pulmonary vasoconstriction, as the name suggests, if there is a hypoxia, your pulmonary vasculature will constrict. Simple. Okay. So, and it's a very unique feature of the pulmonary circulation. In any other organs, if there is a hypoxia, there will be vasodilatation. So hypoxia, hypercarbia in any other organs will cause vasodilatation, but only in the lungs there will be vasoconstriction. And it is a very unique feature of the pulmonary circulation. So we can see here what it does is, if your hypoxic alveoli, if the alveoli here, the partial pressure, alveolar oxygen of it decreases around 85 to 90 millimeters of mercury. So at that point, the vessel which is running at that region will constrict. It will divert all the blood to some normal alveolus which has a higher oxygen pressure. So this is a body's protecting mechanism to prevent ventilation and perfusion mismatch. So let's see what are the conditions which enhances your hypoxic pulmonary vasoconstriction, like hypothermia, acidosis, mild decrease of mixed venous oxygenation, hypercapnia, and if more than 30% of the lung volume is exposed to hypoxia. Now, all this condition will cause less shunt and it will improve your oxygenation. Now, let's see what are the conditions which reduces your hypoxic pulmonary vasoconstriction. If the vessel is distended because of hypervolemia or pulmonary hypertension, or if there is a hypothermia or any type of alkalosis or sepsis, all these conditions will decrease the pressure gradient which the vessel must constrict, and it will cause more shunt and it will deteriorate your oxygenation. Now let's see what are the perioperative drugs which has impact on our hypoxic pulmonary vasoconstriction. Drugs such as our volatile anesthetic drugs, inotropic agents like your dopamine, dopamine, salbutamol, antihypertensives such as your calcium channel blockers, nitroprusside and nitroglycerin. All these agents will cause decrease in the HPV. Our IV anesthetic agents, opioids, dexmedetomidine, your vasopressors like phenylephrine, ephedrine, beta blockers, and epidural analgesia will have no change in your hypoxic pulmonary vasoconstriction, and they are good. So now let's see how your one lung ventilation is done. Till now we have understood the physiology. Now let's see how your one lung ventilation can be done. So we have a diverse category of equipments which can be used for your one lung ventilation. We have our double lumen tubes. We have a variety of your bronchial blockers. We have univent tube. You have endobronchial tube. So I'll not be going details of all of them. So we see here, there's a picture of your double lumen tube, the parts as mentioned in the picture. So there are two tubes here. You can see the two tubes are fused together in your double lumen tube. There is a tracheal curvature and there is a bronchial curvature. There are two cuffs, tracheal cuff and your bronchial cuff. So this tube comes as your right-sided double lumen tube and left-sided double lumen tube. Normally, we usually use our left-sided DLT as the margin of safety is higher in the left side bronchus. Here is a picture of the distal end of your right-sided DLT. You can see a safety feature, the Murphy's eye. This is a safety feature which will ensure ventilation of your right lobe bronchus. So you can see here the distal angle tipped should be placed anteriorly. So this should be placed anteriorly and it should be advanced between the vocal cords. As the bronchial cuff has passed the cords, you turn the tube 90-degree anti-clockwise and push it till you feel any resistance. So this is the manual way how you do insert your double lumen tube. After you position the double lumen tube, you have to check whether your double lumen tube has been placed properly. So you can see here, if you do two-lung ventilation, you can hear auscultation on both the sides. Now, let's clamp one side, the tracheal side. You should hear only breath sounds on your left side. Now, declamp this part and clamp your bronchial side. You should be able to hear breath sounds only on your right side. Then declamp again go for two-lung ventilation. After you go and check whether your DLT tube is being placed properly, now you have to go and check through your fiber optic scope. So you insert your fiber optic scope through your tracheal lumen. As soon as you come at position A, you will see a picture like this. Okay, so this is your carina in the middle. There will be a little bluish tinge of your bronchial cuff on the left, and you should see your right main bronchus.
Dr. Poddar? Yeah, your time is...
2 more minutes, sir. Yeah, done. And as soon as you pass the tube towards the right main bronchus, we can see your 3 structures. This is the right bronchus, which will have 3 orifices. And after that, you take the tracheal, the fiber optic out, and then push to your bronchial side, and we can see your 2 bronchus on the left side. So this is how, based on gender and height, this is how you select your DLT size. For the females, will be around 35 to 37, and for the males, we can choose around 39 to 41 French. So here is the image which shows what equipment can be used at what age. So we can see here, 41 and 39 should be for females, 37 and 35 for your males. The smallest DNT available is around 226 French and should be used for pediatric age group more than 8 years. Less than 8 years, you should try for other methods of isolation. We should follow a lung protective strategy. Pressure control ventilation is much better. You should maintain the plateau pressure around less than 30 centimeter of water. Target volume of around 5 to 6 ml per kg. PEEP of 5 centimeter of water can be used. Recruitment maneuvers to the dependent lung will be better for oxygenation, and ventilation and IE ratio should be managed to get an expected flow 0 or near to 0. If you detect any malposition of your tube, you can get an increase in the airway pressure. There can be decrease in the tidal volume. The pilot balloon might soften up, and the pilot balloon might record more than 3 ml of air. So at that point of time, you should use your fiber optic and reconfirm the position of your tube. So if I have said in my first case scenario, there is a hypoxia, what will you do? Increase the FiO2 to 100%. If it is a life-threatening feature where SpO2 is less than 90% and there is an ECG changes, stop the surgery. Resume your dual lung ventilation. If it is non-life-threatening, you can continue your one lung ventilation. You can find for your treatable cause, like you can use your fiber optic and check the position of your DLT. If there is any secretion of blood, you can do suction. If there is any hemodynamic instability, you can use your vasopressor agents. And you should also meticulously monitor your fluid. You should not overload the fluid. Oxygenation, optimize ventilation in your ventilated and non-ventilated lung. Ventilated lung, you can use your PEEP and recruitment maneuvers, and your non-ventilated lung, you can use your CPAP and apneic oxygenation. How can you optimize your perfusion? Decrease the shunt by improving the blood pressure. Your surgical, the surgeon can itself compress the lung, and if you're going for pneumonectomy, you can clamp your pulmonary artery. So to conclude, the things we have discussed today is your indications and contraindication of one lung ventilation, the physiology of your upright and lateral decubitus spontaneous ventilation, as well as when the patient is paralyzed, the physiology of one lung ventilation, the role of your hypoxic pulmonary vasoconstriction, what are the equipments you need to isolate the lung, and troubleshooting of two things. One is the misplacement of the tube, and one is your hypoxemia. So now two things can happen after the lecture. Either or this. Thank you. Here is a picture of all the how to administer your double lumen bronchial blockers. So you can take a picture. So if you want to see in your free time, you can do that. Thank you.